This session is going to talk about firefighter resource and deployment and EMS modeling and integrations. And I'm going to allow my co-presenter to present himself first, and then I'll introduce myself. So, Denny, why don't you introduce yourself to the group, and then I'll introduce myself.
Sure. My name's Dennis Compton. I was with Phoenix Fire Department for about 28 years. I was a chief in Mesa for another 6 years. I currently still work with the Congressional Fire Services Institute. I'm on the board of IFSTA and also chair the board of the National Fallen Firefighters Foundation. And it's a pleasure to be here with you this morning.
Okay, very good. And I'm honored to be able to present with Denny. Denny's kind of a legacy in the fire service. He's well known, and he's been a fire service leader for many years, and so it's an honor for me to be able to present with him, co-present with him. My name is Gary Ludwig. I got 36 years in fire rescue and EMS. I spent 25 years with St. Louis, and I'm currently a deputy fire chief with the Memphis Fire Department. And some of you may read my columns in Firehouse magazine. I've been writing for them for about 15, 16 years now, and I also write a leadership column in GEMS. And my main role for what I do in Memphis right now is I manage their EMS system. And we're a pretty large system. We run about 110,000 EMS runs a year. And we're going to get into talking about models and whatnot. And I'll talk more about Memphis as I get into the process. But while we're waiting for the screen to go up, I'm just going to ask, how many are you here from? You have populations of more than 250,000 in your community. All right. So where are you from, sir? San Francisco and Vancouver, Washington. Where are you from, sir? Where? Alexandria, Virginia. He works with Adam Thiel, right? He's your chief. That sounds familiar. Where are you from? Vegas? Oh, that's right. We just talked. Duh. You can see my memory. Who else had their hand up? Where are you from? Pittsburgh. Just go around. Where are you from? Where the 250,000 or plus? Where are you from? Toronto. Toronto. Kansas City. Columbus, Ohio. Dallas. Where's another hand up? And that's interesting because we're going to talk about large model systems. And then those of you below 250,000, can I see those hands again? All right, where are you from, sir? Georgetown, Texas. Carlsbad. Topeka, Kansas. Same. Sterling Heights, Michigan. I worked for you guys. I did some work for you as a consultant. Okay. Where are you from? Annapolis, Maryland. Same. What is it? Baytown, Texas. Okay. Where else? Who has their hand up? Breckenridge, Colorado. Did you fly here? No. Okay. When you went downhill, you flew here, right? Where else are we from? Hyannis, Massachusetts. Okay. Is that the same as Hyannis Port? Okay. All right. You got the big bucks, man. Huh? All right. Who else had their hand up? Okay. Now let's kind of break it down even more. Who in here transports? Raise your hand. Okay. So we have a fair amount. Now, who does not transport in here? Okay. So we have a mixture. All right. Does anybody not have paramedics on engines or ambulances here? Anybody? Oh, we have it. All right. So we have a fair amount then. Okay. All right. So anyway, we have a mixture of different models here in the room, and so I think what we're going to try to do today is I'm going to talk about Memphis. We're going to kind of show what I do in Memphis, and then Denny Compton's going to talk about what he's experienced in Phoenix and Mesa, and then I'm also going to kind of give you a background about what different models look like and what EMS systems consist of, and so we're going to kind of talk about that, and I think we're close to being able to start this thing. But it's good that we have such a good mixture in the room today. And what's even more better, or much better, is it's Saturday morning after the Friday night in Denver event, right? And you guys are here. So kudos to all of you. So, you know, you guys are truly must be interested in being educated on different issues. And so you actually, you know, you might have came here to socialize and fellowship, but at the same time, you're also here to learn. So on a Saturday morning, which you know, I think that's very complimentary of all of you. So,
Gary, we're good to go. We just don't have a remote, so I'll change these for you. You let me know.
Roger that. All right. Well, anyway, we're good to go, but we kind of got that out of the way. We wanted to kind of talk about who we got in the room and the different models, and there's just all kinds of different scenarios. Those of you who don't transport, who does the transport in your community? AMR? Who else? Volunteer ambulance? Who said volunteer? Volunteer. Were you private ambulance? Which company? Local or? Family-owned, local? The county does? A third service model? Okay. Who else had their hand up? Yes, sir. Who is that? Pittsburgh? Okay, yeah, they're a third service model, that's right. And what's interesting about Pittsburgh is the EMS does the rescue, elevator rescue, they do everything, right? Well, I shouldn't say that. They try to do everything. You guys actually do everything, right? But that's a unique model where EMS not only does transport, but they also do heavy rescue from auto extrication. Do they still do elevator rescue? They do? Okay. Do they do water rescue? They have a dive team, okay. Okay, all right. But anyway, so that's a unique EMS model in the fact that not only do they do the transport, but they also do what some would consider traditional fire roles also. So, but I'm sure the fire department's involved in a lot of those operations too. So it's a unique situation where the two agencies have to really work close together. So anyway, with that said, Denny, you want to advance me to the next slide? And we'll go ahead and get started. I hear this question all the time, what is an EMS system? And what I like to say is once you've seen an EMS system, you've seen an EMS system. That means that generally it's hard to describe that one EMS system is going to look like the other. A lot of times there might be some slight nuances, but a lot of times there's some radical changes. We've just seen that just around the room here today. You can have cross-trained dual-role firefighters, both paramedics on the ambulance, or you can have a cross-trained dual-role firefighter paramedic and a firefighter EMT on the ambulance. You can have civilians working on a fire department ambulance. We've heard third services, like Pittsburgh and the other. We've heard volunteers, we've heard privates. You know, and then if you start combining that, and we're going to look at a graph here in a second about first responders, you can have all kinds of different models. But an EMS system has some major components. In the EMS Act of 1973, which was passed by Congress and signed by President Nixon, has 15 different components of what an EMS system is. And some of those components are up here, but you know, when you look at system analysis and planning, finance, medical direction, quality management, peer programs, peer stands for public information, education, and resources, our relations, communications, equipment and facilities, human resources, operations. Those are generally common denominators that you'll find in EMS systems. Now, there's also some other documents out there. The NFPA has the 450 guide. If you haven't seen the NFPA 450 guide, you can go look at that. That also talks about an EMS system. It's a guideline to what is an EMS system. So those of you who are maybe just starting out, trying to develop your EMS systems, or those of you that are trying to integrate maybe transport into your system, or those of you that are looking your BLS and you're looking to move up to ALS, you know, those are two good documents that you can reference and look at, and it will kind of tell you and give you descriptions of what are the different components of an EMS system that you have to look at. Because a lot of people think an EMS system is just the ambulance showing up. It is not that at all. An EMS system are different components all integrated together. It starts with 911. The communication person has to be the person who's given the pre-arrival instructions when someone calls 911. You should have some type of first response vehicle. You have the ambulance transport, and then some people consider the trauma system or the hospital within your community also a part of that EMS system. So you have actually major components of a system. It's just not the ambulance showing up like what a lot of people think. Denny? So if you have EMS in your agency, and of course I have some of my biases, you know, where does EMS fall within a fire department? And I think we can conclude that probably 75 to 80% of us that are involved in EMS, your agencies, you do EMS. So I make a comment sometimes, and it pisses some people off, but I make a comment that most fire departments are really nothing but an EMS agency that sometimes goes to a fire call. And that has a tendency to piss some people off. There's a battalion chief in New York, he gets his ears turned red when I say that. And he writes me emails, because I'll put it in some of my columns sometimes, and he gets so ticked off, and we're good friends, but he just gets mad. And, but that's the reality of it. We're mostly an EMS agency that sometimes goes to a fire call. And so what I have seen in my travels, working with the International Association of Fire Chiefs, and I sit on the EMS committee here for the IFF. I also do consulting. So what I have seen around the systems around the country is that you have different models, even within fire departments, of what is the organizational structure for EMS. And is the EMS chief and the operations chief, are they on an even playing field? Or in your agency, does the EMS chief report the operations chief? And it's an interesting scenario. I'm not advocating for either one, because I've seen both work. Because usually what makes it work is the personalities. Because if you have an operations chief that has an EMS chief underneath them, and they get along well, and they talk well, and they have a good relationship, and they communicate, everything's cool. And I've also seen it work well. That's how I work in Memphis. I'm a deputy chief, just like the deputy chief over operations. And in our two areas, I can't tell you how much they cross. Because I have firefighter paramedics riding on engines, and he's got firefighter EMTs riding on my ambulances. And so our areas overlap so much, but we talk all the time. We communicate all the time, and we have a great relationship, so it works. I know of another community in Tennessee, same scenario, operations chief, deputy chief, as you see on the left over there, same level playing field. The two guys hate each other. They don't talk to each other, and it goes all the way down their chains of command so that there's just total headbutting between fire and EMS. And so one of the things I advocate, and I'm a big proponent of fire-based EMS, is that EMS is not the stepchild of the fire service. It's on an even playing field. It's on the same level. It's most of what we do. And it's not to diminish what we do on hazmat and firefighting and other things, but at the same time, it is a major component, and so it's an integrated model within the fire department. Denny? So when I talked earlier, you can add up, if you take the column on the left and mix it anywhere on this graph with what's on top, vertical and the horizontal, you can come up with all kinds of different types of EMS systems. If you look at the column on the left, you can have fire department transport, cross-trained dual role. You can have firefighter civilians on the ambulance. You can have private for-profit ambulances, like AMR. You can have public utility models. Anybody know what a public utility model is? Anybody from Fort Worth here? Kansas? Where was Kansas City? Kansas City was here. Kansas City was a public utility model prior to being merged into the fire department. So were you guys with MAST, or were you were with MAST? Okay. So a public utility model is basically, it's a quasi-government agency that owns all of the equipment. They own all of the administration. They do the billing. They do all those types of things. But then they lease out, I shouldn't say lease out, but they contract out the manpower component or the staffing component to a private ambulance typically. And so that's a public utility model, but they're heavily reliant on the fire service to do first response transport. Fort Worth, an example of that. Kansas City was at one time. Tulsa, Oklahoma, Pinellas County, Reno, Nevada. I'm trying to think, there's one more. Is it Gary, Indiana? There's not many public utility models around out there. And it was designed by an economist by the name of Jack Stout. I won't dig off on this much, but Jack Stout had no fire, no EMS background. He was an economist. He was a consultant that got into doing EMS consulting. And he based a lot of theory on public utilities models on what they call system status management, which means you move your ambulances around to where they think and predict where the call volume is going to be. The unfortunate thing of that is he based that model off of elevators, how elevators work. If you have a high-rise building in your community, and there's an elevator, if it's 55 stories, in the morning, those elevators all are programmed to go to the bottom floor, because that's where the demand's going to be at. People are coming to work. People are going to come in. They're going to take those elevators and go up to the upper floors. In the afternoon, those elevators are all programmed and staged at different areas. They're staged at floor 35, 45, 55, because everybody's going to be leaving work that day, right? So they're moving the elevators where the demand is going to be. That's the same theory that Jack Stout used for a public utility model, and that is they're going to move ambulances around to basically accommodate where the call volume is going to be, predictability. So we won't get off on that too much, but you can have third service operations like Pittsburgh, and somebody over here, they had a county operation somewhere. Was that you back there, sir? You can have ambulance districts. Missouri, anybody, there's some people here from Missouri, from Kansas City. Anybody have ambulance districts? It almost works like a fire protection district, in that you have a board of directors that's elected. It's a political entity that is established by law, and they have a board of directors that are elected. So that's an ambulance district. You can have the military, volunteers. I heard somebody say there's a volunteer back here. Helicopter operations, hospital-based systems. Anybody have a hospital-based transport in their community? You have the hospital owns the ambulances, okay? And you can have private, not-for-profit. And if you combine those with the first response, you can have BLS first response, ALS first response, no first response, or you can have BLS first response and just defibrillate. There's no medical trained people on there. So if you were to mix and match those, you might come up with about 80 different types of EMS systems up there. You can have private for-profit with ALS first response. Who said you were from AMR, you had AMR in your community? Do you have, what type of engines do you have? ALS, BLS? BLS, okay. So you could have, that would be private for-profit, the third one down, and the first column, which is BLS first responder. So that would be his system there. And Las Vegas, you have ALS engines? Okay, and ALS rescues. And so that would be the first one on the left, fire, cross-trained dual role, and ALS first responder. So I can take any one of your systems there. Now, and see, there's another hybrid. Then they also got, they share transport with AMR. So you could actually create a third column over there somewhere. So you can come up with about 80 different models of what an EMS system might look like when you mix and match all these different things. So you're from Alexandria, right? What do you guys, what type of, who does transport? You guys? Okay. So the people on the ambulance are fire personnel. But they're civilians? Okay. So they're civilians. So, and then the engines do what? Or ALS, BLS? BLS. So it would be the first column BLS, looking down to second one on the left there, fire civilians. So you see how it works? I can take anybody in the room here, and we can mix and match your system. And anyway, you'll come up with about 80 different systems. So I wanted to show that to you. Go ahead, Denny. All right, I'm going to profile the city of Memphis just a little bit to kind of tell you what my system looks like. But we got about 347 square miles, about 850,000 population. I never been to Memphis until I got hired. I went down there. I always thought Memphis was a smaller city. It's a big city, and I finally realized why. They really don't have any Major League football teams or baseball teams or that sort of stuff. But there's a lot of people that live there, so it's a big system, a big department, and it's on the Mississippi River. And FedEx is our, and it's a major road from going east to west, and truck system, and FedEx is based there too. So it's a major transportation hub. Go ahead, Denny. We got about 1,800 personnel, 57 stations. We do about 110,000 EMS runs a year. 23,000 are fire runs. We got 56 engines. That 57 station is at the airport. 27 ladder companies. I have 36 ALS ambulances on the street. We had about 500 firefighter paramedics, 1,100 EMTs, and then 3 heavy rescues. Go ahead, Denny. And we're one of the few fire departments in the United States, there's not many, that we actually train our paramedics in-house. So when you get hired as a firefighter, you actually go through our academy and you become a paramedic also. And now I know there's some places like, who was Dallas? Where was Dallas? Dallas is right here. You're required to become a paramedic when you come into the department, correct? But you don't train them in-house, you send them over to UT with Deb Case on. So So anyway, so Dallas is another system where you're required to become a paramedic, and they recognize, you know, if somebody has the vision and recognizing that, hey, that's where we're going, that's what we need paramedics, and but they train them outside the department. So anybody else like that here that train their own paramedics in-house? I know there's a few. Columbus, Ohio, you train paramedics in-house? Okay, cool. All right. Okay. Now, we have a unique situation here. I think about the only 3 cities in the country, and correct me if anybody knows if I'm wrong, which I'm never wrong, but anyway, once in a while I'm wrong. I like this joke. I'm never wrong. I thought I once was, but I was wrong. So anyway, but we're unique today in the fact that we have Columbus and Dallas here. I think those are the only 3 cities with Memphis that every engine is ALS. Am I correct? You guys, every engine is ALS? Every engine is ALS? I know in Memphis, every engine is ALS. Where's that? Vegas, okay. So yeah, okay, we'll include Vegas. I'm talking about metropolitan areas when I talk about it, you know, the only cities. Does anybody, you guys know of any other cities that are like that? I don't know of any others. So, but you know, that's a commitment that apparently the administration's made some years ago, that we're going to move to an all ALS level. So all 56 of my engines are ALS. I looked at the numbers this morning on my email. And I got enough paramedics that 7 of the ambulances are doubled up also. So there's 7. I have 2 of my ambulances this morning that are in Memphis that are also got 2 paramedics on them besides a firefighter. The rest of them are firefighter EMTs. So so anyway, there's only a few cities that are unique like that. So you could also create, when we talk about that model system, we can also kind of create that up there. So, but anyway, so we're one of the few departments. I know Columbus, Tacoma, Washington, I think Baltimore County, Maryland. There's not many fire departments that train paramedics in-house. All righty, Denny. All right, I'm going to turn it over to Denny, and then he's going to talk about the city of Phoenix.
Thank you, Gary. Let me do something with you right quick so I don't forget, okay, because they'll be after me if I do. You all have an evaluation form in front of you. Please don't fill that out until we're finished, except for the session ID. You see that area up there, session ID? I need to give that to you. And it's EM03D, as in Delta. So EM03D. There aren't a whole lot of people I know in our industry that is as well versed in EMS as Gary is, and it's always a pleasure to work with you, and it's a pleasure to work with you not only in sessions, but in other arenas where we get to as well, and I'm going to talk about that here in just a few minutes. One of the systems I want to talk with you about is a system in the city of Phoenix. I spent 28 years in the city of Phoenix. I left there as assistant fire chief. Phoenix is an interesting place. It really is when you look back historically at the fire service there. When I went on the fire department in 1970 in Phoenix, there were 490 members of the fire department, 490. When I left in 1997, there were 2,000. So we got to do something most people don't get to do, and that's build a metropolitan fire department. We actually got to build one, and we got to build it at a time when EMS was just coming in to the industry, okay? So it was really, it's a unique place. Phoenix is a huge city. It's one of the largest cities in square miles in the country, 520 of them, and it's 1.5 million people. It's always right there in the top 5, 6, 7, 8 cities in the country. It's Philadelphia, Phoenix, San Antonio, and San Diego. Just keep trading places every time that there's a census done. As far as the department overview, there's about 2,000 personnel in the Phoenix Fire Department. There are 58 fire stations. They do about 1,000 or 150,000 EMS runs a year and about 14,000 fire runs a year. And Gary, gotta hate to do this to you, but they have 65 ALS engine companies. They are all ALS engines now. We can add Phoenix to that, but only in the last 2 years. Before that, 3 years. Before that, they had a mix. We had a mix of ALS engines and BLS engines, okay? And have any of you tried that? Some ALS engines, some BLS engines? What was your experience with it? Uh-huh. Uh-huh. No, go. Uh-huh. That's just what I was wondering if you would get to. Because that's what happened in Phoenix, is that as that system matured, way too often you ended up having 2 engines on the scene and a BLS ambulance on the scene. And you essentially had a residential assignment, fire assignment on EMS calls. Yeah. Mm-hmm. Does that kind of an issue become a public concern at all for you? Or is just where I'm from? There's a fire department ever get beat up once in a while about the amount of resources that shows up on an EMS call? Who beats you up? Uh-huh. They see it as what? A waste, yeah. Now it's interesting because and Gary would tell you that when we first got into ALS engine companies, or even engine companies that were going to respond on EMS calls, BLS, that was done for a productivity reason, believe it or not. Because when we first started out, we had 2-person EMS units in Phoenix, 2-person EMS units. But they couldn't handle the call volume, and their response times were outrageous. So from a productivity standpoint, to take advantage of the people that you have deployed throughout the system anyway, it just made sense to do the other. But it became an issue for Phoenix, and finally, 3 years ago, they finished. It took about 3 years to do it because of the training and everything involved in the cost. And they did it right in the middle of an economic downturn, which was amazing that they were able to do that also. But they converted every engine to ALS, and every rescue is ALS. They have 34 rescues, which are ambulances. It's just called rescues, but they're ambulances, and they're all ALS. As I said before, there's 14 ladder companies and 3 heavy rescue units throughout that city. Okay, so their system is really full ALS out of every engine company. BLS ladder companies, ALS rescues. Okay. And we're not here today to talk about which is the best system. We're not here today to do that at all. Even when we talk about your systems more here in just a little bit. The fact of the matter is you have to do what fits where? At home. At home where they have to fund it, at home where you have to represent it, at home where someone has to manage it. So it has to fit there, okay? City of Mesa was another place I got to spend 6 years of my time, which was a lot of fun. I went over to Mesa, and it was really a great opportunity because Mesa wanted to change. I mean, Mesa is a metropolitan fire department. Mesa is the 39th largest city in the United States, and they were way understaffed, underdeployed, and they needed to grow up, if you can imagine what that means as far as an organization is concerned. And they truly wanted to, which made it an even better experience for me. You don't often get to go somewhere where the mayor and council, city management, and the members of the fire department, the command staff and the union, are all pretty much on the same page as to where they want that fire department to go. That was like a gift, okay? I wasn't intending to leave Mesa. I had been there 6 years. I had planned to stay at least 10, but I bought my military time when I went over there. It was always too expensive in Phoenix. I bought it when I went to Mesa in a different retirement system. And I'll be doggone, I ended up eligible for for a retirement window there that they were offering. So I went home and I talked to my wife about it, and I explained to her what it was, and she told me it was an intelligence test and that I better pass it. If I had stayed 10 more years, I couldn't have made up the difference. So I found out in August of 2002 that I was eligible, but I had to be gone by November 30th, or I would lose the opportunity. So it all happened rather quickly. But Mesa's 180 square miles with room for growth. But the interesting thing about Mesa is if it grows to the east, it's going to go into a second county, which is very rare in the state of Arizona and causes some jurisdictional issues. 470,000 population, that's actually up closer to 500,000 right now. And within the boundaries of Mesa, we have a number of what are called county islands. You all have those in your jurisdictions? Anybody? We got one here that does. What's a county island? I know Vegas has them. What's a county island? It's an unincorporated area that exists within what? The boundaries of the city. It has not been annexed in. You get paid for yours. Some do. Some have agreements where they get paid, okay? And they create incredible political headaches to the point where the fire department can't win. They can't win. If you go into a county island, you're providing service that people aren't paying for. If you don't go into a county island and something bad happens there, what do they say about the fire department that wouldn't respond? You can't win. So I always told our troops that if you're going to get me in trouble because you went. I would rather be in that trouble than in the other trouble, okay? Because you think about it. You live in Mesa, city of Mesa, and you drive across a street, and I mean, it is just that simple. You drive across the street. Someone hits you head on 100 yards down the road, and the Mesa Fire Department that you pay taxes for won't respond to you because of those darn county islands. That goes over like a lead balloon. You can't represent yourself in that. You're going to lose. So I mean that. If you're going to get me in trouble because you went. Go deliver service. We'll worry about the rest of it later. We didn't invent county islands. We can't change them, and we're not going to be a victim of them. Was always mine. And they're still there. To this day, they're still there. And we don't get paid for the responses. And what's really aggravating about it is you all know Rural Metro Corporation, right? Chapter 11 now, okay? Well, people talk about privatization, and it's, oh my God, privatization's coming. Do you know I've never worked a day in a fire department that I didn't have to deal with privatization? The Rural Metro Fire Department was in Scottsdale, Arizona, and in other places when I joined the Phoenix Fire Department. They've always been our neighbor, and not necessarily a good one either, okay? Who was getting paid by prescription to protect those dang county islands? Who do you think? By subscription.
Rural Metro?
Rural Metro Corporation.
Really? Wow.
And they deployed their resources in a way that provided same-day service. Okay? So it's just, it is a no-win situation for an EMS system or for a fire system, but where's the majority of your calls? EMS. So it's a daily occurrence from an EMS standpoint, okay? So if you have county islands, it'd be interesting to see where they fit into Gary's model when you start plugging private companies in there that don't respond in a timely way. You know? As far as Mesa is concerned, they've got about almost 500 personnel. They just hired about 35 personnel for the first time since the economic recession started. They operate 20 fire stations, 53,000 fire and EMS runs. Something unique about Mesa, and Gary, you can put this on your list too, and I don't know of another fire department, at least in my area of the country, but while I was in Mesa, we went to all ALS engine and ladder companies.
Wow.
Every engine and ladder in Mesa, Arizona is ALS. Okay? In other words, there is no delay in that response. There is no multiple company responses. You know, we operated a very busy system there with only 20 fire stations. So you didn't have the luxury of sending 2 and 3 companies to a single EMS call. You just didn't have the luxury. What it did was increase response times like crazy to other parts of that city on a daily, hourly basis. So we had to do something else. And what we did, and we did it in the labor management process, is that we decided to distribute all of that equally across the board. All ALS engines, all ALS ladders. And I'm very proud of that system. It's still that way today. The ambulance service in Mesa is contracted to Southwest Ambulance and has been all along. Southwest Ambulance. Southwest Ambulance used to be a privately owned ambulance company. Okay. Bought later on by who, do you think? Wasn't AMR, Rural Metro. Rural Metro bought Southwest Ambulance, okay? All the ambulances that operate in the city of Mesa are also ALS ambulances. And what that does for that system, and it really helped us out, is it when you have a BLS ambulance that's picking up ALS patients, what do you have to do with the medics that responded on that call on the engine or the ladder? What do you have to do with them? They have to go with the ambulance, right? They can't just abandon the patient. They have to go with the ambulance, okay? When we started requiring, while I was there, ALS ambulances, we were able to transfer care over 80% of the time and put that engine and ladder right back in service. Right back in service with both medics. Once in a while, one of the medics have to go with an ambulance, but that's not often. Over 80% of the time, right back in service to do what? Take another call. Any of your units get tied up at hospitals going to pick up medics and stuff? They're out of their first due response areas, or is that also only where I'm from? It's a pain, and it puts those units out of service for doing what? Delivering service. And it's amazing when you get in this labor management process, which I can't encourage people to do enough. In other words, those decisions can be made in a labor management environment. It's amazing what you can do with your system. When everybody's focusing on 2 things, delivering the best service you can to the public and doing the best job you can at taking care of the people who are supposed to be doing that. When that becomes your focus, there's no limit to what you can do. But when there is a labor management process that is based on conflict, and I look around the room here and I see some darn good, positive labor management situations that I'm well aware of. But when it's not, how much harder does it make changes like that to make? I mean, you think about it. I'll see your idiot and raise you an imbecile. And here we go. Talking about everything but what? Delivering service, taking care of the people who are supposed to be doing it. Boils down to personalities, and it gets ridiculous. Okay? So those are 2 departments. We're going to come back to that open discussion here in just a second. I'm going to wrap up my portion here, and then we'll do it all together here in just a minute. One of the things I get to do is in 2006, myself and a guy named Steve Austin. Steve Austin is from the Volunteer Fire Service out of Delaware. And he is one of the most influential people politically in the fire service, and he truly is. He still is to this day, and he's semi-retired. But he and I formed a consortium, if you will, coalition, called the Fire Service-based EMS Coalition. It's based in Washington, D.C. And the reason we formed that, and Gary could speak to this better than I can, but the fire service-based EMS systems were being left out of some important discussions and critical studies that were being done. I read some studies, one out of Georgetown University, that I swear to God, if you didn't know fire departments did EMS, you couldn't tell they did by reading that study. And there are several like that. There were plenty of instances. Plus, there was legislation being proposed that was not going to be in the best interest of fire service-based EMS systems, legislation at the congressional level, and we needed to deal with it better than we were. We need to come together. So look at the group that forms that steering committee that Steve and I chair. You get that group of people together on any issue, and that's an interesting Coalition, the International Association of Firefighters, and Lori Moore, Merrill, represents the IAFF on that coalition. The IAFC, and Gary Ludwig represents the IAFC on that coalition. The Congressional Fire Services Institute, which is involved regularly in congressional issues and agency issues as well. The National Fire Protection Association and the National Volunteer Fire Council, which is amazing when you get those groups to come together to work on issues regarding fire-based EMS, and that's what we focus on, fire service-based EMS, okay? We don't advocate against any system. We advocate for fire service-based EMS systems, okay? We don't waste our time bad-mouthing systems. Now, people ask me all the time, Denny, what can we do to help, you know? Because I work in Washington, D.C. once or twice a month. You all here at the IAFF have one of the absolute best government affairs groups that the fire service has to offer. Okay, Kevin O'Connor, they don't come any better than Kevin O'Connor in that business, okay? People say, what can I do to help with some of this? Well, from a standpoint of fire-based EMS, here's what you can do to help if you'll just do it. It'll take you all of about 10 minutes, okay? You see that website down there at the bottom of that slide? That's the website for the Fire Service-Based EMS Advocates Coalition. If you go to that website, you can join your local, you individually, or your fire department, or a combination of the three, can join the Fire Service-Based EMS Advocates Coalition. It doesn't cost anything, and you don't have to do any work afterwards. But when you're working with Congress on issues and federal agencies on issues, and you say you're advocating for a position, how much does it help you to have a whole bunch of other organizations that have signed on to your coalition? And people, too. It makes it appear what? That you're doing what? You're truly advocating for a large group from throughout the fire service, volunteer and career. And it really increases your influence. If you go to that website, it'll give you instructions on how to join. Okay? It's very simple. And I would really encourage you to do that. And make yourself a note to do it. Put a message on your phone or something to do it. Because once you leave here and go home, the chances of you doing it diminish significantly. So do it. You can help. Say, what can I do to help? My God, I just found something I can do to help. Even if I can't travel, I can do that for sure. Another thing that Gary, this is just the home page for the EMS Advocates. You can see there's all kinds of materials there for you. And we recently, last year, in fact, started a best practices area of that. So there's all kinds of best practices from organizations who have been nominated for or actually received national awards for their EMS systems. And you can see what are other people doing that might make sense for us that have already been acknowledged. Go ahead.
Can I just say one thing,
Please.
Denny? As long as he's talking about this is so important. I just want to.
Please.
I don't want to. But Dallas is sitting here. Did AMR put together a proposal several years ago and approach your city leaders and said they gave 5 points on why the Dallas Fire Department should not be doing EMS transport? About 4 years ago. And they put together a nice booklet. They bypassed the fire department. They went and said, we can do transport, and had 5 different components on why. Thankfully, they beat it down. But that was, AMR was now, they approached Dallas, they approached Los Angeles, Cincinnati, Omaha, and what Denny and his leadership, what he did here was we put together a toolbox. And Denny, why don't you talk about that toolbox?
There it is, right
there.
there.
It is. I didn't know you were going to have that up there.
Go ahead, please.
No, but we needed to get information out to the fire service that these bastards, I'll just say it, you know, we're trying to come in here and take over and ruin our communities when it comes to providing service to our citizens. And so we needed to educate the fire service on creating a toolbox, what we need to do for unions and chiefs on, this toolbox provided information on how to beat this crap back. So anyway, it's through like leadership of Denny and Steve Austin that created this program, And now we're working on, because we see community paramedicine become another issue for fire service, because we see the privates entering this area, and it's going to become a major issue over the next 10 years, I guarantee you that. And we're putting together a toolbox as we speak in preparation for, again, unions, labor, management can use as a reference or as a tool about community paramedicine and the issues that you need to be up on and be aware of. But that's some of the things that what Denny and Steve had done. He's a humble man, but because of his leadership, we're here today talking that we can educate people in the fire service on issues that are important to us, and we have one resource we can go and get that at. Go ahead, Denny.
You ask who are the people that put something like this together. The people that put this electronic toolkit together in 2010, by the way, was when this was finished, late 2010. It was the IFF, it was the IFC, and it was the Metropolitan Fire Chiefs Association, and then I coordinated it, okay? So that's where the toolkit came from. What we're doing right now, as Gary alluded to, is we're revising this toolkit, and we've got a goal to have it out to you by December 1st.
It's free.
And it's free.
Yeah.
And you can find it on the IFF's website, you can find it on the IFC's website, you can go to the website that I gave you a few minutes ago for Fire Service-based EMS Advocates Coalition. It'll be there. It's already there, but the revised one will be there. So all of the initial, instead of doing two separate toolkits, we decided to do one. And where does all this come into play with deployment models? When you're looking at your deployment models, it's important that we have the capability to quickly find research that has been completed, studies that have been completed, articles that have been written about systems, you know, and how do you defend your systems, talking points to help you do that. So we're going to have one toolkit, but it's going to have, this one's going to have two sections. It's going to have one in general fire service-based EMS, just like here. And the second section is going to be the ACA, the Affordable Care Act. And we've already made our assignments to each other, and we're getting those things together right now, in fact. Matter of fact, by September 6th, we're supposed to have them to the person who's going to do the
That's
first
our homework
draft
assignments from you.
Yeah. Yeah. I've already got mine in, by the way.
Okay.
I don't know if you noticed. I
No,
copied
yeah.
it. Okay? So there's a lot going on with this, and it's important, I think, that we try to, if we can, to stay on top of it. You have a slide that says what I said just a few minutes ago about who puts that thing together. And you know, I mentioned labor management relations. I'm going to do a little plug here before we start talking about your systems. There are hardly any books that I'm aware of on fire service labor management relations. There just aren't many. I know I've written some on it, it's in one of my books. There is another book that was recently published about it. And then this guy, any of you know Brian Jeffries? Okay, Brian is an incredible young man. But he is also the president of the United Mesa Firefighters Association, which is the union that represents 5 fire departments in the eastern part of the valley, in the Phoenix area. But he's also the vice president of the State Firefighters Association, the Professional Firefighters of Arizona. And for quite some time now, he's been working on this book, and he just finished it, and he self-published it. So there, again, I've right here for you, and I hope that you jot this down, and at least consider contacting Brian, see if it's something that you might be interested in. And you can see his email address right there. brian.n.jeffries@gmail.com. You say, well, why in the world talk about this at a class like this? All the things that we talk about in here, I'll say it one more time, all of it involves change. It involves managing in a way where you're quick on your feet. If we don't deal with some of these ACA opportunities, at least evaluate them in the next 1 to 3 years, what could happen to our EMS systems? And I'm not an extremist, but what could happen? Anybody? Close your eyes and imagine a fire service without EMS. And if you think you're going to like that, you know, I think we all have another thing coming. Some of the decisions that we're going to make in the next 3 years in our systems, 3 to 5 years, but especially 3, are going to be as important as the decisions that were made by your predecessors, your union presidents, and the fire chiefs in the 1970s and early 80s about EMS in the first place. They're going to be that important to our system. Do you agree with that, Gary?
Absolutely.
Okay, and I'm sure.
I would go so far as to say, and I've wrote it in Firehouse Magazine already, that if you don't get on board with the ACA in 10 years, it can look drastically different on fire-based EMS. We could be out of the business, quite frankly.
And will it affect your models, your deployment models, like crazy, okay? So I thought it was a good thing for us to at least mention here today. Now, I'd like to turn this back over to Gary, and I'll participate with you, but we want to talk about your models. So what we're going to do is ask you, if you will, to describe your models, and what are the pros and cons of those models, so that not only do we look at the 3 we brought, but so that the class gets to listen to what else is out there. You did 2 or 3 of them already, but we want to hear more. So Gary, why don't you lead that discussion?
Okay, sure, Denny. And I'll just quickly, before I launch into it, I'm just going to say yes, the ACA, Affordable Care Act, it's not mandatory. I'm sorry, it's not voluntary. It's mandatory. It's the law. There's 2,700 pages of law passed by Congress, signed by the President, affirmed by the United States Supreme Court in 2011. And the earliest, and I know the Republicans want to get rid of it, the earliest a Republican's going to be in the White House, maybe, is 2017. Maybe. And by then, the law will be in effect for 3 years, because it starts in 2014 here. It'll be in effect for 3 years. It's already some of the components have already started. You know, my daughter, she's 23. She's still on my health insurance. She can stay there to 26. You know, the cap of $1 million is gone. Some of the other components are gone. But start enrolling people on, you know, into insurance programs starts in, you know, soon, and it starts in 2014. So in 3 years, it's going to be it's going to be totally in play for 3 years before the earliest a Republican president can maybe launch an effort to kill it. And then you probably have to have both houses of Congress in order to support that. And now he's got the House of Representatives, but I don't know if the Senate's going to change hands or not. So it's coming. There's 14,000 pages of regulation that have already been written about this law. So it's not an optional thing, it's mandatory. And I can tell you the privates like AMR, they have positioned themselves for what's coming. They have been bought out. Did anybody know they got bought out by a private equity firm? Does anybody know that? They got millions of dollars of capital resource behind them. And they have started, they got 2 divisions. They got a division, which you're all familiar with, where they transport. Now they also have they got 2,200 or 2,600 positions that work for them. Did you guys know that? In a company called MCare, where they lease out or they staff emergency rooms. They have started a whole new 3rd division of community paramedicine now. And if you read the advertisement, it's designed to integrate with the after-hospital care of the citizen or the patient in the community. They're going to offer that service because what the Affordable Care Act does, I don't mean to get off on this or not, but it creates 3 things: quality of care, savings, and also trying to think of the 3rd one now. I have a mental block. But anyway, there's 3 components: quality care, savings, and trying to think of the 3rd one. But anyway, the bottom line is the savings part is what I want to talk about. And with the savings, what's going to happen there is that the affordable care, that's the other 3rd component. I knew there was something. All right, it's affordable care. The savings is where hospitals and these accountable care organizations are going to form these groups. There's already 200 plus accountable care organizations in the country. They're going to share the profits. The goal is going to be to keep people out of the hospital and to basically treat them at home and get them treatment before they become too ill. So we're still going to have 911 systems. There are going to be shootings, there are going to be auto accidents, there's going to be heart attacks. But what we're going to see disappear, I predict, is the chronically ill. The asthma attacks, the diabetics, the people with CHF, those types of patients are going to be taken out of our system because they're all going to be enrolled in healthcare programs and their care is going to be managed. I know once, where's Dallas? Let's talk about Fort Worth. You're familiar with Fort Worth. They've already, the EMS system there has changed their name already because they're involved in already all kinds of out-of-hospital, non-EMS type of stuff. They changed their name from Fort Worth EMS to Fort Worth Mobile Healthcare Solutions, did it? So they don't even have the name EMS in their name anymore. So, because they're doing all kinds of things with CHF patients, people who are in hospice care. I'm trying to think of all the different programs they got going on. And they're making money. the hospitals are paying them to basically do this type of work. They're paying for a nurse in the 911 center $90,000 a year to screen 911 calls to get them out of the system so that the patients don't come to their ERs and clog their ERs up and cost them money. So this is where we're going to. Who's from Phoenix? I know Denny's from Phoenix. Anybody else from Phoenix here? Jeff Clark was here making a presentation about what the Phoenix area is doing. 23 fire departments, along with the labor, have formed a coalition. They're going to create a community paramedicine program. 9 different committees are working on different issues there in preparation for that, so that they can approach the hospitals in the community and the ACOs and become a part of that plan. So they can deliver that. They're going to have 3 different components. I'm off on a tangent, I'm sorry. After hospital care, a robust treat and release program on scene where they get paid $500 by these accountable care organizations to basically treat and release the patient at the scene. And the third component is a nurse navigator type of program in the, again, the communications center to screen those calls out so you don't go on bullshit calls. So
how could this affect our deployment models? Mesa, Arizona, it changed their name about 6 months ago. It was approved by the mayor and council to the Mesa Medical or Fire and Medical Department. So they don't use EMS either. And they've entered into an agreement with the medical community, with hospitals. They've got 2-person units in service right now on this community paramedicine issue with a fire paramedic and a physician's assistant from the hospital on those units to try this out. So one of the neat things about sharing information is that all these things are being tried in different places. Do you remember when the NFPA started the safe cigarette thing? And they decided they were going to have a national campaign for safe cigarettes. Remember that? Just a few years ago. Did you notice that after about 6 months they abandoned that effort? And what they found out was that the laws were so much different in every state, and the regulatory agencies were different in every state, and one template to do this wasn't going to work in every state. So they actually regrouped, retooled, and decided to do it on a state-by-state basis. That's what you're going to see with this ACA thing with regards to your deployment models. There's not a template nationally because the emergency medical services aren't regulated in the same way in every state. It's not managed in the same way in every city. So you're going to have to look at these opportunities that present themselves. And you're going to have to decide for yourself locally which ones apply to you potentially, which ones can strengthen us, which one can strengthen our systems. Because there's not going to be some template out of the sky. Now, we can identify 3 or 4 or 5 things. He could do it off the top of his head that everybody's going to have to consider. But there isn't a here's what we got to do thing. Or is that, would you agree with that,
absolutely.
Gary?
And, you know, and I don't think this segues into this because we're talking about deployment models.
Yes, that's what we're talking about.
And our models are going to change. So, but I'm curious, when we talk about models, those of you who work with private ambulances, raise your hand.
With private ambulances.
With private ambulances. You work with private ambulances. I'm just curious, what type of relationship do you all have? Is that something that you've tried to become part of the ALS transport? Or you don't want to do that? I mean, because when we talk about what works for your community, works for your community. And you guys might be happy with AMR. Maybe you're not happy with AMR. Maybe you're not happy to do the transport. So I'm just curious what your thoughts are on that. Why don't you start off? And talk loud so everybody can hear you.
The system in San Francisco is a little bit different. You talk about all the different kind of models. 44 engine companies, about 30, on a daily basis, probably 30 to 32 of them are ALS. The rest are BLS. So
you're from where, San Francisco?
San Francisco.
You got a private you're working with? Because you guys do your own transport, though.
We do our own transport. The state of California, the state EMSA, has just reissued our exclusive operating area for the city and county of San Francisco. That's the other thing that we're unique about.
You might lose transport?
No. We're
okay.
No. Well, we could.
Okay.
Because our chief and her ops chief have their heads buried in the sand, thinking that one of the mandates in the EOA says the fire department is going to be responsible for 80 to 90% of all 911 calls, 911 system calls, not private calls.
Okay.
As such, obviously, that's going to take money and staffing and infrastructure, yada, yada, yada. So they have made no contingency to make sure that that happens.
Okay.
The $14 million that they're going to need, the additional 18 ambulances, that sort of thing. But that exclusive operating order is based on providers that were in the system back in 1980. And that is, at that time, it was the DPH.
I don't mean to cut you off, but,
Yeah.
but let me just say, so for those of you who are not from California, California is unique in the fact that your states regulate EMS. California, the state doesn't regulate EMS, it's the counties, right?
Correct.
So
The state oversees them,
state oversees them.
but each local EMSA or each LEMSA is pretty much autonomous.
Right, they're a very autonomous organization. So when they're putting out these types of documents, it's not on the behest of the state, it's the county doing this. And they might have great relationships with the privates. When you just told me you have to have been in business, what, before 1980?
Yeah, so it was the 3 providers that
Oh.
were in the city in 1980, and at that time it was the paramedic division of the DPH, but it was still the city and county.
Okay.
So now it's the fire department. But the remainder of that call volume is going to be handled by AMR
Okay.
and another private company, King American.
You know, when we talk about AMR, and I hate to talk about the 800-pound gorilla in the room, but they got money, man. They got money to come in, and they got lobbyists. One of their tactics is, just so you all know, they will hire somebody very influential in your community that has influence that can get to the decision makers. Is that what happened?
Well, Falk.
Falk. Oh, there's another name.
Another great one, yeah.
Oh, everybody even know about Falk? Okay, you got a hand up back there. We're going to talk about Falk in just a second.
You got a guy here too.
Falk hired
Hold that up so we can hear you.
Yeah, Falk hired a retired, or actually our retired EMS section chief, Pete Howes.
Really?
To-
Pete jumped ship?
Yeah,
Okay.
before the ink was dry on the
Okay,
separation
all right.
papers. But
I've always
So he-
wondered about people take their money from the fire service, get a pension, and go and.
he's getting a big fat one, but
Okay.
I digress. Anyway.
I'm not saying anything bad about Pete. All right.
Yeah, so he jumped ship. He went to Falk. He's our consultant. Falk owns a piece of Pro Transport One in the city. They've just now applied for an ALS operating permit, and the fear is that when the first review of our EOA comes up at the end of the year, and we're probably not going to meet those mandates, that Falk will probably
Step
come
in
in
there.
and say, they're not doing it. They're supposed to be at this level by December 31 of this year. They're not doing it. We're going to come in, and we want the system open again, which obviously is going to take away revenue from the department and can affect membership.
So you're going to lose calls. You might even lose your ambulance service, what I'm hearing. So, but those.
Hope
Let
not.
me just say one quick question. We talk about AMR. Falk is the other 800-pound gorilla in the other corner, and in the room. And did anybody know about Falk? I saw one hand up. Some of you know. Largest private ambulance service in Europe. Now I think they're the 3rd largest. They come to America just recently here in the United States. I don't think they've come. Anybody from Canada here? I don't think they're in Canada. But they're about making money. They're the largest private firefighting operation in Europe too, and they see money now with the ACA here in America, and now they set up shop in California and other places too. So anyway, but talk about your relationship with AMR. You guys comfortable with them?
Yeah, we're from Topeka, Kansas. We've had AMR since they bought out the family-owned ambulance service in the mid-'90s, and it's been like dealing with sinister evil the entire time.
Okay.
How about that?
All
They
right.
hired the assistant.
That's being nice, probably.
They hired the assistant director for the Kansas Board of EMS, which happens to be located in Topeka.
They
to
hired
be
one of the
their
influential
directors.
decision makers.
Incredibly influential decision maker,
Okay.
and he fights us on every turn as we're attempting to go to ALS engine companies. They fight us. They bring their medical director in and say, we shouldn't be doing this. There's no way we can provide this services. On and on and on and on. He's made comments about bringing in privatization for our fire service, all kinds of things.
Who has the medical director?
Their director,
Really?
the AMR director, to do the same thing that they try to do in other cities, buy fire trucks and bring them in. They're very, very difficult to deal with. They've moved their dispatch out of our area.
How does that translate down to the operation on the scene?
It's horrible.
Okay.
We have long scene times, waiting on them. They'll use us as their manpower They have a bariatric ambulance, but we're the horsepower that puts the bariatric patients
I call,
in the ambulance.
Yeah, you guys are the mules that do
Yeah,
their work.
absolutely.
But they get the money.
And they'll call us on emergent and
Yeah,
non-emergent
yeah.
runs whenever they need horsepower, whenever they need manpower. But obviously, they don't want us to get any piece of that pie.
If we could click our heels and go back in time, what would you have done differently if you, and I don't mean don't get into it with the privates in the first place, what would you have done differently that would have perhaps headed off those issues that you're facing today?
I've been an EMT and an EMS for 20 years. I think that we really missed the boat early on in getting into that ALS service, to get connected with our community, to provide that in our engine companies, to get in on that ground floor and provide that services, additional services above and beyond the plain first responder that we do now.
I've been doing this 36 years. I started when I was 18 with St. Louis. And the guys back then, 30 years ago, were going, we're not nurses. We don't want to be on these fire trucks as a nurse. We don't want nothing to do with EMS. Now it's changed for the most part. And now we're hearing the paramedics of today going, we don't want to do anything with community paramedicine. We don't want to do anything with the Affordable Care Act. We're not going to go in those homes and do that type of stuff. And that's the same rhetoric that probably was said 30 years ago, and you guys missed the boat. And if we don't get on board with the ACA right now, we're going to miss the boat. And the guys 20 years from now, we're going to go, those guys 20 years ago, they missed the boat. So just think about that.
I think in reference to Chief Compton's question, put yourself in the position today, and I think it's the same question. And what we're dealing with is providing a better value to the citizens. So the things like community paramedicine, critical care, transport paramedics, the things that are above and beyond, and it has to be comparative to the threat. We're dealing with that right now in our little microcosm up there, but it's looking for the new avenues of service, what you can provide the citizens, where you endear the citizens to you, so when it comes time for that decision-making time, there's no question to the politicians, the citizens, no, these are our folks. This is what they do for us.
Right.
So I guess my challenge, my question to you is what are those? What have you heard? What have you seen? What are some things that we can offer to increase the value of our services?
You want to take that, Denny? Or?
I'll take the first one. We can just share it. One of the things that many of your fire departments do currently, how many of your fire departments do all-risk public education programs? Not just fire and burns, but falls and things of that nature. The bicycle safety helmets, car seats. Services. I mean, think about it, okay? A huge emphasis in the ACA is going to be on preventing issues that cause people to be at the hospital. Okay? One of the things I think is an opportunity for us is to get involved in these healthcare coalitions that Gary was talking about. Get involved in them now and explain to them what you do and can do for them, because I think there's revenue for you in that.
And really jobs.
Do. And jobs.
Yes.
I think that we already do that, and we do it very, very well. And so all risk education, public education, that you already do in a lot of fire departments, you know what that is, don't you? That's an EMS prevention program. It always has been. We've never called it that, but that's exactly what it is. Okay? So that's just one thing that's a little off the charts that we already can do. And I think there's money in it, and I think it positions you as professionals in that process. So Gary, what you jump in?
I'll just add a few comments on the Denny. I call it the 4 Ps. Pursue possibilities to promote your perception. That's what you need to do. And you need to be so strong in your community and so loved in your community that when you come with these new innovative programs and these new ideas, that they're readily accepted, that they're accepted because they have such a respect for you, and they already have respect for you. But you need to also, as I said, the 4 Ps: pursue possibilities to promote your perception. But what Denny's talking about is added value services. And before anybody starts throwing tomatoes at me, when I talk about the ACA and that we need to get involved, and I'm not talking about doing it with your existing resources. I'm saying there's opportunity to add jobs to your departments.
They're going to pay someone to do that.
Right.
That system's going to pay for that.
Exactly. And give you money. On top of that, it might be used for other things too. So we're not talking about, well, you know what, I'm already running 5 calls a day, 6 calls a day. Now you want me to go and check on some guy at his house? No, I'm not saying that. I'm just saying we have an opportunity to add more people to the job that can take care of those issues while you're still running your 911 systems.
In your current system, what's the definition of turning a patient? I mean, I came out of the field for years and years and years. We turned a patient when we turned it over to a hospital, and we did not see him again, right? We turned the patient. That definition could change. And it could be that that patient gets turned back to a system that somehow follows up to keep them out of that hospital. Because people not changing their bandages properly, not taking their medications, not doing other things is what causes people to be back at the hospital within 30 days for the same event. You have a question. Go ahead.
Real fast before you say something, Jim. Denny just said, did you guys know that the hospitals are getting penalized, not paid if someone's readmitted within 30 days again?
Yeah.
You guys know that? Their goal is to keep them out of the hospital.
They're going to go on a secret probation list, too.
Exactly,
Double
double secret probation.
Yeah.
Go ahead, Jim.
Well, you just hit on one of the points, excuse me, one of the points I was going to make is that they're being penalized 2%, and it was 1% last year. It's now gone to 2%. So it's costing these hospitals millions of dollars. So one of the things that we're struggling with is how do you fund these programs? Yeah, they're great, and we want to get involved in it for what you're talking about, but we've met with one of our local hospital systems, and they're tripping over themselves trying to help us because you're right, they do get penalized for like heart failure patients at 30 days, and there's an opportunity for funding. If you can demonstrate the value, they will help you fund it. So that's one point. The
Matt
second
Sabansky from Fort Worth, who runs their part of their system, and there said, he said those exact words. The hospital said, "How much do you need?" We still see savings if we fund you doing these types of things.
most of these hospitals have heart failure clinics, and so they see their patients through the clinic, but they are more than happy to take the patients that you bring, so there's that quality assurance relationship. It's all, you know, it's not worried about HIPAA protection because of that, and push them back out to you so you can help them keep them out of a 30-day kickback.
I read an article, and I wish I could remember where it was at, but it was how they're managing the CHF patients to keep them from being readmitted. They put a scale in their house, a special type of scale, and then once a day the patient has to step on the scale, and it Bluetooths over to a connection to the internet, which then goes to their health center or whatever center they got, so they can look at the patient's weight, and they can chart it each day. So if the patient starts gaining weight, guess what? He's probably putting on, or she's putting on water weight. So guess what happens in the call center or this place where their data is being transmitted to? Next thing you know, they're getting a visit from someone saying, "What's going on? You're not taking your medicine. We need to adjust your medicine. You eating pork salt, or what are you doing? You know, you're gaining weight. We want to get you before you go into CHF completely and have to be admitted to the hospital, where we're talking big bucks to take care of you in the hospital." So that's some of the things that innovatively we're going to use technology in the future to manage the care of people in the homes. And again, this whole concept is there's opportunity for jobs and money for fire departments here.
And I guess my second point is to your comment in the back, and that is we are value added to the customer and so forth. But my point is, prove it to me, show me. A lot of what these third service and other agencies are doing is they're creating dashboards. I mean, the two things that we benchmark are response times and return to spontaneous circulation rate. Outside of that, what do we tell the public about, you know, our customer satisfaction rates, and how do we measure those things such as pain management and all those other things that go with it? And until we start pushing this information out through our website about, you know, all these different opportunities to we're very data rich and knowledge poor, is I guess the point I'm getting at. And these other organizations are damn good about using their data to drive the fact of efficiency and demonstrate to the public of how value added they are to them, and we need to mirror that.
Absolutely, I agree with you on that.
One of the things I've seen in the larger metropolitan areas is there's not just going to be one of these coalitions for healthcare management. There are going to be multiple ones.
Absolutely.
And how important does politics get in that? When you talk about we want to be a part of that, we want to be represented there. And then you look, one of the things I've said is always one of the critical aspects of managing a fire department is partnerships, relationships, and politics. It's one of several, but it's one in a system. And you have the upper hand in that. We have the upper hand in that. We're a good partner. If you were going to form a relationship between yourself and other potential people, who would you pick? What's the public image of your partner? And how active can we get politically to help those systems be successful? You know, those are things that we're thinking, because they affect these deployment models for the future. Okay? We got time for just maybe one more question, Gary.
And when I'm in, and I know we don't get, but who has a major issue going on in their model system, their model? And I want to hear about that. I think everybody want to, because there's a reason why most of you are probably here. Denny, there's a hand up over here. Tell us where you're from.
My name is Matt. I'm from East Pierce, Washington,
Okay.
which is basically a suburb of the Seattle-Tacoma metropolitan area. Our organization currently is First Response ALS. We had a model where we're basically 6 career stations, 5 volunteer, about 152 square miles. We staff 5 engine companies, a ladder, 4 medic units. On any given day, we used to have where all of our engine companies were ALS. We've kind of gone away from that because of financial stuff in the last in the last couple of years. We're now trying to get back to, as we hire, to maintain, to go back to that first response on everything. And we're kind of coming up against different ideals, those ideals being, I believe you talked about it yesterday, that there's too many medics in the system, that their skills degradation, that kind of stuff. And so for us, it's kind of a tough battle right now, trying to convince our department that, hey, this is the right thing to do. And they're, by the way, they're very forward thinking about the community paramedic stuff. Our EMS CQI committee has put together all kinds of stuff using the data to try and sell to our public the great things that our paramedics do. So I guess any additional help.
Okay. So what's the big issue? They're not letting you go all ALS, or
Yeah, they're essentially
who's they?
The administration of our organization.
Okay.
We have a differing of opinion right now, and through labor management, we're trying to create a better outcome. But that's one of the huge challenges is many of our people got hired as firefighter paramedics, and they work on an engine company. As we continue to, grow and lose medics, more and more of them are stuck riding the box, and that becomes kind of a morale issue because they were told a different thing when they got hired. And
My guys rotate. They're 12 hours on the engine, and they're 12 hours on the ambulance.
Sure.
And so, so I mix them up so that they, and you're right, that nobody wants to ride the box all day long. Maybe some do. I got some guys that say, hey, I won't take my 12 hours on the engine. I'll just stay on the ambulance. That's where I want to stay. But let me tell you what I wrote, if it just helps your situation. I wrote this in Firehouse magazine several years ago. Why would you want a BLS engine when it can be ALS? Take it on the reverse side. Look at the fire side. Why would you take hose off the engine? Why would you take water off the engine? Why would you take some resource that's on the engine that can deliver service? Why would you take that off? So the same thing applies to EMS. Why would you take a resource such as ALS capability off the engine? It doesn't make any sense to go backwards, because we might not need ALS on every call. We might not need a hose on every call. We might not need water on every call, but it's there if we need it. And so why would you take a resource and take it off of there and make it less capable? It doesn't make any logical sense. So I don't know what the reasoning is. Maybe it's economics, but even then, those are issues that probably can be worked through. But again, that's my take on it. Why would you take a resource off, apply it to the fire, not to be repetitive, take it to the fire side? Why would you take water? Why would you take hose? Or why would you take some other piece of resource capability off that engine? Why would you take ALS off? It doesn't make any sense.
What's the solution to a problem in service delivery when you don't do a lot of it, but when you do, it's really important? In other words, you don't get the experience you wish people got with it out in the field But when they do need it, it's really important. What's the solution to that?
Training.
Training. It's training. If you took that logic that the reason we don't want to go ALS is skill degradation, we wouldn't have any firefighting units. Because how often are we doing that now compared to other aspects of our work? In other words, we have made up for that difference through training.
Hey, Chief Ludwig, yesterday you said the day that a doctor sends out a letter that says there's too many doctors in the system.
Yeah, let me, I'll just repeat what I said yesterday. There's this argument there's too many paramedics out there. You might have seen the studies and that sort of stuff. Well, there's too many paramedics, and that means there's only 50 intubations that are going to be done in his community. So the more paramedics you have, the less they're going to intubate, so there's skill degradation. And my argument to those doctors who write those studies and do those studies is, when you show me the study there's too many doctors, then we can talk. And then they usually shut up. So I said that with Frank Pratt in there yesterday. Frank Pratt is the doctor from LA, and he's a great guy. But that's my take on it. Don't tell me there's too many paramedics. When you tell me there's too many doctors, then we'll talk. But don't come into my shop and tell me there's too many paramedics. So anyway, and I'll tell you, if you're worried about skill degradation, my QI guys in Memphis, we target anybody. We look at high-risk, low-frequency type of events. If they haven't intubated in 6 months, we target them, we bring them into the skills lab, they practice intubating. It's no big deal. We can take care of that. It goes back to training, just about what Denny Compton just said. So,
we have to wrap this up. They said they wanted us to start on time and end on time, okay? Just in closing from me, look at that Fire Service-based EMS Advocates group. There's no reason in the world why everyone in here couldn't join that today, okay? Please don't forget your evaluations. They want us to be sure that we ask you to fill those out. And the answer to your question regarding how could you go back and do it better, it's if you could have control of that performance contract with that company all over again, would you have done it differently? And it's that performance contract that's critical. So with that, Gary, it's always nice.
Yes, it is. And it's been a pleasure working with Denny here. And I hope that we've been able to give you something that you can take away from here.